I would request the moderator, Dr. Arulmozi Ramarajan.
Now, if we want every pregnant woman to live beyond her pregnancy, we need to attend to those complications, and those complications in the backdrop of anemia to make them survive that pregnancy. So in this panel of 40 minutes, we'll deal with 3 clinical situations which are complications of pregnancy, and all of these 3 women are anemic. Anemia and infections are responsible for about half of all maternal deaths, as you can see from this diagram, and the risk of maternal mortality in women with severe anemia during pregnancy and postpartum really pushes them to death. I mean, whatever complication they go through, it pushes them to death if they have been anemic. So that's the importance of this panel, and this study which I showed that the odds of maternal death were twice as high in those with severe anemia compared to those without anemia. So let me introduce the panelists to you. We have Dr. Rajeshri Palladi, please acknowledge, Dr. Shanta Devi, Dr. Meena Muttaya, Dr. Tejavati, Dr. Shailaja, and Dr. Rekha Rajendra Kumar. They are all senior, busy, practicing obstetricians. So what we will look at will be a situation of severe anemia and an obstetric complication in addition to it. The cases that we'll discuss will be severe acute anemia due to hemorrhage, example in a ruptured ectopic pregnancy, then one on acute chronic anemia in labor, that's severe PPH, and one puerperal sepsis as a complication of pregnancy in an anemic woman. So in the first situation, panelists, we have a second gravida, previous LSCS 14 months ago. She presents with 2 months of amenorrhea and has severe lower abdominal pain since 1 hour, and she collapses in the emergency room. The question is, what's your diagnosis? Even without those findings, perhaps you can make a guess. She is very pale, she has tachycardia, she has tenderness, marked tenderness in the lower abdomen, and cervical movement tenderness is there. Dr. Tejavati.
It's clear-cut ruptured ectopic pregnancy.
Absolutely, and there is no doubt about that. So it's a ruptured ectopic pregnancy. Now, what are the challenges in this situation, Dr. Shailaja? I want short answers.
So here they will have excessive bleeding, so that is hemorrhage. So there will be decompensation. So the need to resuscitate them with the fluids and the blood transfusion immediately.
Okay.
And we have to stop the hemorrhage, important.
Okay. Now, what I really want to say is that she is now severely anemic because she has bled enough to collapse in the emergency room, and she also is facing an emergency surgery. It's not just resuscitation, she is also facing emergency surgery. So now we'll go on to a rapid fire of 3 questions. We'll start with Dr. Rajeshri. Do you wait for blood, or do you go ahead with surgery under grave risk?
Here the first and the most important point is to stabilize the patient and make sure that her volume is well compensated before we go for the surgery. And definitely we know that in a ruptured ectopic pregnancy, controlling the source of bleeding in most of the times would elevate the blood pressure.
It's a rapid fire.
Yes.
You want wait for blood, or you want to go ahead?
No, we want to go ahead.
You want to?
Make sure that the blood is called for.
1 or 2.
Go ahead.
Go ahead.
With the grave risk.
Excellent, excellent. So the point which you said, that you will stabilize her and go in for surgery, I think can be modified. You will just go in for it, because unless you stem that bleeding vessel, hemorrhage, she cannot be stabilized. Do you all agree?
Yes.
Okay.
Can
It
go
should
for
be
simultaneous
absolutely
resuscitation.
simultaneous. Okay, next. Now she is B negative, and B negative blood is not available. Can we give O negative, Dr. Shanta?
Yes, madam. In emergency situation, we can give till we get the compatible blood.
Very good. So it can be given. And B negative blood is available. There's no time to cross match. Can you give her an uncross matched B negative blood, Dr. Rekha?
Ideally, no.
Yes
if
or no?
Yes, we can
Yes.
go.
Would you
Yes.
take the risk?
Yes, definitely I'll take the risk consent and take risk and go with B negative uncross matched.
Very good. I got all the answers the way I wanted. So the general management would include appropriate communication, consents for therapeutic interventions including surgery, transfusion, and team management of course is required. Then obstetric management I don't have to touch. The transfusion part of it is what is important because we are dealing with that severe acute anemia. So component transfusion as against whole blood transfusion is the order of the day. You will have to give early and give enough. So organize for adequate units of blood. Massive hemorrhage should ask for massive transfusion. Now we will talk about massive transfusion in a few minutes. Group and type specific blood is the best of course, but if it is not available, O negative or group specific blood, don't worry about the type, can be given, and uncross matched blood can be given in dire emergencies. Most important would be documentation and debriefing. Documentation particularly because it's a grave risk situation and you may be doing any of those unconventional things in transfusion also. Debriefing is important because the patient may not be in a shape to give consent, understand and give informed consent in her situation. So debriefing to her and to her family will be important after the situation settles down. Now in the second situation, we'll go from Dr. Rekha. This is an unbooked primigravida and she comes with labor pains. She is very pale, unbooked, very pale, and she has not carried any reports on hand. What precautions would you take to deliver her safely?
History wise, I'll take the history because she is unbooked to me regarding all the necessary things where she had the antenatal checkup and whether she has a lab reports and sonography reports which will throw some light to me.
What precautions would you take to deliver her safely?
The second thing is I'll send her blood for CBC, the hemoglobin, and I'll get the hemoglobin estimation and also the blood group since I don't have all her reports. So because suppose it's a Pala 3 plus, the blood hemoglobin may come around 5, in which case I'll keep the blood ready for her and assess her how
so
much
you
she
have
is in
addressed
labor.
her severe anemia, right?
Yes.
Okay. So quick clinical assessment, available antenatal records if she is able to. Then as Rekha very rightly said, hemoglobin, blood group and type are very important, and you will also check availability of blood and organize. It is also important to screen them for infections because the caregivers will be at risk in an unbooked patient. And you should also find out if she's been handled outside, etc. Those are the routine precautions you would take with any unbooked patient. And flag the inpatient record for risk factors. Unbooked gravida should raise certain issues to be documented, and anemia should be the other flag. Now she has a very tardy labor and it's augmented, but then she arrests in second stage and has an emergency C-section, baby extracted. There is PPH on table and you have assessed her blood loss. Dr. Shanta, class of hemorrhage is important. When you assess hemorrhage, class of hemorrhage is important. So what would you call as a class that warrants blood transfusion immediately? Class 1, 2, 3 or 4?
So in class, if it is more than 25% of loss, that is more than 2,500 ml. But in already anemia patients, even normal blood loss is you have to address.
Absolutely.
So depending upon the cause for anemia and the blood loss, there's more than 1,500 ml loss. But in anemia and preeclampsia, even less than that.
Even smaller losses
Loss also you
can
have to
behave like class 3 hemorrhage,
Yes,
right? So that's very nice. So how much blood should the woman lose to drop her systolic pressure, Dr. Rajshri?
The woman generally compensates up to about 20% of the blood loss.
How many ml or how many liters will she lose before her systolic pressure starts dropping?
It's about 1,000 ml before her systolic blood 1,000 to
much
1,500.
Yes, 1500 to 1800 ml should be lost before systolic pressure
Blood pressure
drops.
drops.
1000 ml would go into class 2 hemorrhage.
That is class
and
3.
There is tachycardia in that stage, but when she starts becoming hypotensive, it's already in class 3. So how do you remember this, what class of hemorrhage and how much of her blood is lost? Now, if you all are tennis fans, you can remember the classes like this. Remember the tennis scores and the classes come one after the other. So up to 15%, it is 0 to 15%, low 15. So no loss to about 15%. Class 2 is 15 to 30%, so it is 15-30. Class 3 is where we have hypotension, that's 30-40, and that's the score also. And more than 40% loss, the game is almost over. When would you decide to transfuse, Dr. Shailaja?
Transfusion depends on her stability, hemodynamic stability, and also her baseline hemoglobin. The hemoglobin threshold, so at which we have to transfuse, is roughly about 7 gram%, above which we have to transfuse. This is restrictive strategy for the blood transfusion. But it depends on her hemodynamic stability as well.
Very good. So hemoglobin alone will not decide. I think the timer is not good. Yes. So 7 grams per deciliter for the hemodynamically stable adults and 8 grams% for those with comorbidities. Now we are dealing with all comorbid patients, therefore we will go with 8 grams per deciliter plus. The decision to transfuse should not be based only on patient's hemoglobin level. Now this is a very important point because it's not a straight equation here. Hemoglobin does not indicate the level of tissue oxygenation. Here tissue oxygenation is affected, and direct measurement of tissue oxygenation using other methods like the metabolic indicators, base deficit, lactate, etc. are required. Those plus the hemoglobin level should be more relevant to decide on how much and when to transfuse. Dr. Tejavati, what is MTP?
Medical termination of pregnancy.
Got it. Massive transfusion protocol. I mean, this was...
Of course, in this situation, it is definitely massive transfusion protocol.
Yes, but then you can also do a medical termination in an anemic pregnancy and get into trouble, right? Okay. So what is massive transfusion, Shailaja?
Can I answer?
Yes.
In this situation, 4 transfusion in an hour, you can call it as massive transfusion.
Okay. Any other definition?
Whole blood replacement in 3 hours, even that is massive.
Whole blood in 3 hours.
50% of the, 50% of the blood volume
Whole
in 3
blood
hours.
in 3 hours, we should also follow her to heaven or hell.
No, 50% of the blood volume in 3 hours is a massive blood
Okay.
transfusion.
Dr. Rajshri?
Is that when it necessitates to give more than 4 units of packed cells
Massive
in 1 hour,
transfusion.
massive
Okay.
blood transfusion.
Dr. Shanta?
Whole blood volume in 24 hours,
Yeah.
or if it 150 ml per hour.
And
There are
Dr.
so many
Rekha, do you have
definitions.
anything to add?
No, I have nothing to add.
Okay. So massive transfusion is replacement of one entire blood
24
volume in 24 hours, transfusion of more than 10 or 20 units, different definitions, of PRBCs in 24 hours, or more than 4 units in 1 hour, replacement of 50% of whole blood. So I've got all the available definitions from my panelists, and that's excellent. And in such a situation, the protocol is called massive transfusion protocol, and that's MTP for you. It is not just waiting for blood loss and giving one after the other. It is a proactive standardized protocol where early administration of fresh frozen plasma and platelets also will be given to decrease the incidence of coagulopathy and improve survival. That's the importance of MTP, or that's the standardization that's brought in. When MTP is activated, that is, when a call by the clinician goes to the blood bank, the blood bank will issue in 5 to 10 minutes time a predefined pack of RBCs, FFPs and platelets immediately for transfusion. And that is the next question that goes to Dr. Rekha. What's the ratio of PRBC, FFP and platelets in the MTP pack? Is it 421, 211 or 111?
It's 421.
421. And anybody differs? Yes. So
It is
we
1:1:1 and a single.
Okay,
SD.
so we have this extreme 421, that extreme 111.
111.
Okay. It's actually either 211 or 111, which means the amount of PRBC and FFP should actually run parallel and almost equal. Now the ratio recommended is 211 or 111, and what the pack contains is uncross-matched O negative PRBCs, group AB or low titer group A plasma, and group AB or A platelets. Yes? Trauma. Yes.
Whereas an obstetric patient has got a lot of pro-coagulant factors.
Agreed.
And maybe the ratio that we're talking about with trauma patients may not be applicable to an obstetric population.
May not be applicable. But on the contrary, in obstetric hemorrhage, by the time this blood arrives or the products arrive, there's a
Already
lot
there
of
in DS.
crystalloid infusion and there's hemodilution. And hemodilution is already there in pregnancy. So coagulation factor dilution
diluted.
is quite a possibility, and therefore studies are not there to sort of compare it.
6 RBC transfusion, about 50 ml per kg body weight of FFP.
Agreed, but
We need to have the coagulation profile also, depending upon.
absolutely, this is
need more
just
work
a
on
startup.
this,
More work on it is required to compare what information we have from trauma hemorrhage to obstetric hemorrhage. But as of now, what we understand and what's being given by the blood banks is either a 211 or a 111. Now, the next question is, what are your targets of resuscitation in massive blood loss? Dr. Rajshri, targets of resuscitation in massive blood loss.
Is first to bring up her blood pressure to a systolic of 90 or a mean,
Systolic of 90, okay.
and then see that she doesn't, make sure that she doesn't lose further blood. Oxygen saturation is most important, and see that she doesn't develop into lactosis. Or
Okay. Okay.
The target should be, hemoglobin should be more than 8 g%, platelets should be above 75,000, fibrinogen should be above 1.5 grams.
That's the blood resuscitation.
Yeah.
Here it's general resuscitation.
Urine output should be more than 30 ml per hour, and oxygen saturation should be above 92%.
Very good. So our concerns, very rightly answered. The blood resuscitation part of it is exactly as what we heard from Dr. Shailaja. The hemoglobin should be more than 9 grams per deciliter, because if it's 8 or 8 plus, close to 8, we will be still transfusing because there could be some more ongoing loss happening. Platelets and INR should also be within limits,
Normal
because
limits.
we have to look at the coagulation profile also.
Yes.
And coming to her general condition, systolic blood pressure should be 80 to 100, as Dr. Rajshri put it, and more than systolic or diastolic,
Mean
it's the mean
arterial
arterial pressure, like our previous speakers also mentioned in the first session.
Should be 60.
What else will you do to save the situation, Dr. Teja? Is there anything else you will think of? We've given fluids, we've given blood products, antibiotics, oxygen, etc. Anything else
We
that
have to see the source of bleeding,
Yes, so now in this lady, it is
uterine atony.
PPH on table. So all the protocols for medical and surgical management of PPH will be addressed. Anything else out of the box?
When you have
Anybody-
corrected
anybody-
Can I
everything,
answer?
you can give.
I will think of two situations. One is when we are transfusing her so much, especially with the top-up of crystalloids, overload, fluid overload and pulmonary edema, and second thing is sepsis.
No, no, what I'm wanting is any other measure that you would give to, yes, cell salvage.
Cell salvage?
Difficult
No, if
to-
you have corrected everything, all the coagulation factors and blood, something out of a thing is factor recombinant
Yeah,
factor
quite good.
7.
Quite good. Something even closer to our.
If at all the hemorrhage is not responding,
Check
then
her
we can think of replacing the factor.
Okay, so we have arrested bleeding as per PPH protocols. We have given blood products quite early. Cryoprecipitate apparently is beneficial in obstetric hemorrhage even more than what it is in trauma-related hemorrhage. Tranexamic acid and recombinant factor 7A have also been brought in, and there are studies to tell us that tranexamic acid is pretty useful. Now, early administration of tranexamic acid in bleeding trauma patients has been shown to be significantly helping in reducing mortality. But you see that study there, the first one called the woman trial. The woman trial is actually tranexamic acid for the treatment of postpartum hemorrhage. It's an international randomized double-blind placebo-controlled trial, and it has shown that this is a useful measure to reduce blood loss at section.
This tranexamic acid timing also within 1 to 3 hours only it has a role, not beyond.
There are studies where a prophylactic shot of tranexamic acid 1 gram given prior to the cesarean section has
wherever we anticipate hemorrhage, we can do that.
Yes, you could do that.
Then
because it needs some time to act. Therefore, giving it prophylactically, or if you are just in the situation, give it earlier the better. So, key points for bleeding after birth. So, admissions for labor should all have HB blood group and RH type on the front page. Blood should be reserved and documented as to how many units are available, particularly in the high risk women, and from which source or blood bank. Restrictive episiotomy policy, avoidance of operative deliveries will all minimize loss. AMTSL, of course, is the rule in all women. Then putting in the flags for risk factors is also a good practice for hemorrhage, for convulsions, for sepsis, for anything. Coming to hemorrhage, the mild and moderate ones will be handled or tackled with crystalloids and colloids. Massive ones, MTP. Obstetric management includes uterotonics, massage, compression, tamponade, etc. This is important because we sometimes maybe miss doing this. Patients who have received blood transfusion and who were not able to give valid consent prior to the transfusion should be provided with information retrospectively. Actually, there have been situations where in an unbooked gravida, the patient has to go in to the OT for whatever procedure. The OT mandates that screening should be done before taking her for any procedure, is it not? So HIV, HBsAg screening and all should be done. So this is just an anecdote only to make us remember it well. So the resident, because the resident didn't have enough time to send the sample, get the report from the lab, said HBsAg, HIV negative, and pushed the patient into the OT. Then after an hour, the report, lab report came saying HIV positive. By that time, the patient had received some transfusions, and now the husband is up in his arms to say that she was negative, now you have made her positive. So this situation could arise. So all unbooked gravidae and all documentation should be true and actual and factual. Okay, next question. If this patient were to refuse blood transfusion, Dr. Rajshri, what would you do?
Is that give her adequate crystalloids?
Don't we end up in hemodilution and coagulopathy because of dilution?
Madam, there was a case report wherein a patient who had a massive blood loss, and she was a Genova witness. She refused to take the blood transfusion with a valid consent, wherein the only thing which could be done was to stabilize her, to resuscitate her, to revive her, maintain her blood pressure, and maintain the hemodynamic status, and see that the urine output is maintained. And then once she stabilizes,
so essentially crystalloids.
Erythropoietin can be given.
So here in these situations where they refuse blood transfusion,
autologous transfusion,
you have some measures to save the situation.
Also
one
the
is to
the harvesting.
Yeah, two things. One is autologous transfusion, the other one is the intraoperative cell salvage.
Okay,
but that also we should take consent from her.
Everything needs consent.
But then that requires a lot of preparation, any kind of transfusion.
But few people will be willing.
Jehovah's Witness, particularly as a category, must be sort of talked to, and whatever dialogue happens must be documented right from the antenatal period. And it should be a one-to-one dialogue with the doctor, because some of them will agree to some product transfusions, not all. And they are in sort of a fear of being excluded from the group if they agreed to these product transfusions in a group discussion. So a one-on-one discussion should be done and documented. The same should be reconfirmed at the time of admission. And then you have to have your strategies to minimize blood loss, conserve blood, and to increase tolerance to anemia. This is what I wanted to say. Conserving blood, one by prophylactic tranexamic acid, then of course intra-op cell salvage, much talked about but less done, and normovolemic hemodilution. Increased tolerance to anemia, mild to moderate hypothermia, of course again we don't practice it, and hyperbaric oxygen therapy. Now I just mentioned it because in one such patient who had a hemoglobin of 2 grams, she was successfully managed with pulsed hyperbaric oxygen therapy, erythropoietin, etc.
Collide, madam.
It's part of the resuscitative measure, yes. Now, how this happens is, at rest, the oxygen delivery is normally 4 times the consumption. That is, there's a lot of reserve. And therefore, if the intravascular volume is maintained during bleeding and the heart is functioning well, oxygen delivery will theoretically be adequate until the hematocrit falls to even 10%. This is because adequate cardiac output plus increased oxygen extraction by the tissues. In that emergency, tissues will extract more oxygen from the blood, and that can compensate for the decrease in arterial oxygen content. So, I mean, this is just to
and we should make sure patient is kept warm so that her oxygen consumption comes down. Cold, opposite. Hypothermia is part of the management.
Hypothermia. So that there is a peripheral vasoconstriction. So that there is peripheral vasoconstriction and the blood is diverted only to the vital organs.
It is hypothermia. Okay. Madam, protocols on PPH management, I am not touching because it's NASG. NASG can be applied. Yes. Fall. It will.
Prophylactic.
Absolutely. NASG use. Absolutely, madam. Thank you. Okay, activated factor 7 and cell salvage can be also brought in. Now, the third situation, we'll start with Dr. Tejavati. Now, this lady, 22 years of age, delivered her first baby 4 days ago at home after being in labor for 3 days. She is brought in with fever, chills, rigors. What is the probable diagnosis?
Puerperial sepsis.
Yes. What is sepsis, Shailaja?
Sepsis is a clinical syndrome where it is characterized by systemic inflammatory response. So there is inflammation of various organs and tissues.
If she has an infected episiotomy, would you call that sepsis?
If it is spread to the entire...
so there should be just not the local
It's not the
problem.
local infection, it is systemic inflammatory response.
So it's by definition a life-threatening organ dysfunction due to dysregulated host response to infection. Therefore, the infection spreads and there's a systemic inflammatory response. Now, what is septic shock, Dr. Rajshri? We'll go a little faster.
Yeah, it's the state.
This is the last case.
Due to the reaction to the organisms and the body response, that the body, there is hypovolemia.
There is
although
sepsis,
there is no
shock.
blood loss. Yes.
Yeah, yes, exactly. So the blood loss may not be much, but the
intravascular volume is reduced.
Body's response to the sepsis is what gives the shock. So it's persisting hypotension requiring vasopressors to maintain a mean arterial pressure of 65 millimeters of mercury or higher and a serum lactate level greater than 2 millimoles despite adequate volume resuscitation. What is SOFA? Anybody?
Sequential organ failure assessment.
Very good. It's excellent. Now, that tabular column is not for you to try and read. It's just too full. It's just a way in which the various organ systems are assessed by both clinical and lab values, and scores are given for each organ's function, system function. And that includes lungs, circulation, metabolic acidosis, kidney function, coagulation, and cognitive dysfunction. So that is SOFA. Now, do you think we can do this SOFA score or SOFA assessment in our practice?
It takes time.
It takes time. We need lab work.
Lab investigations.
Is it not?
Yes.
So there is also a shorter
quick
version.
SOFA.
Quick SOFA.
Q SOFA.
So that's the Q SOFA, and this relies only on clinical assessment. There are only 3 things to be looked at, that is altered mental status, a respiratory rate of more than 22 or higher, and a systolic pressure of 100 millimeters or less. So if 2 or 3 of these are present, then the lady is said to be in septic shock. Next question. Does she have any identifiable risk factors? Our patient who delivered at home, Dr. Shanta?
Yes, madam. Said home delivery must be in an unhygienic situation.
Very good.
And anemia is important predisposing factors for sepsis.
Okay, and she's been in labor for 3 days.
3 days, so prolonged labor, premature rupture of membranes.
Yeah, we don't know.
So
We'll have to put her risk factors on paper. Yes. So risk factors for sepsis will include, see, the first 3 our lady had, that is prolonged labor and home delivery, malnutrition and iron deficiency, and of course immune compromise, because in iron deficiency there is immunological deficit. Other risk factors which may be documented in appropriate situations would include abortions, surgery, catheterization, prolonged hospitalization where they get extra inputs from hospital acquired nosocomial infections, and of course other system infections and antibiotic abuse. So in the backdrop of anemia, that would spell double trouble. And the anemia factor in sepsis, if you just see, the whole thing really brings the patient to a situation of oxygen debt, and anemia fuels this, and how we manage each of these is what we discussed just now. The question is, would you increase the oxygen carrying capacity by resorting to general measures, positive pressure ventilation, PRBC, or IV iron? Quick answers, one word.
Definitely pack red blood cells.
3.
We have to increase the
One word, 1, 2, 3, or 4. Time up.
PRBC.
Okay, all of you? Dr. Rajshri, PRBC. Dr. Shanta, Rekha.
transfusion.
All of you say PRBC, but there is controversy. What to do? Blood transfusion practices in sepsis.
Actually, IV fluids, madam. IV fluids, and we should bring
Patients
bring
with,
up the-
I'll just give the message because we'll be asked to vacate the place.
Deprived.
Packed RBC transfusion is in the early goal-directed therapy for severe sepsis and septic shock, has not made it into the latest surviving sepsis guidelines as a graded recommendation. However, it can be used or rather customized to the situation. Now the same thing, the guidelines do not advocate, they restrict RBC transfusion in
to
adults.
less than 7 grams.
Okay, so we'll just remember this. Whereas same fresh frozen plasma. Now the sepsis, surviving sepsis campaign is what we'll have to look at for our first our bundle for management of septic shock, etc. That is why this is projected. Platelets also, suggestion for platelet transfusion would be
The threshold.
no threshold for trigger for
10,000 not
trigger.
bleeding, 20,000 who's bleeding, and 50,000 who's going for surgery.
Excellent. To summarize, blood and blood products are indicated when specific situations warrant and additional research is needed in this area of critical care, regarding blood transfusion. Now she's out of the ICU and her HB is just 9. Last question. Can we give her intravenous iron? All of you answer please. Yes, no, yes, no.
9 grams not required. We can actually bring it up with oral iron.
We talk about optimization, no? Then why do you let her lose at 9 grams? You will give. You will give? Rekha?
No, I will not give.
You will
because
give? Shanta? After 48 hours. Okay. I beg to differ. We are finishing. We should not give intravenous iron when there is sepsis.
Yes.
So avoid giving intravenous iron, though it's very tempting to optimize with this.
So addition of oxidative stress actually when we give
It adds to the oxidative stress, and it also worsens the sepsis because it helps the bacteria to
Yes.
get more DNA, RNA produced.
Yes.
Okay. So that is it. Thank you all very much for
Thank
that
you so much.